Right. So let's start. So we've started with maternity health for the past week, last week, and I told you we are tackling every corner of maternity health. Okay, before we leave. So just stay tuned, and also I need your attention to grab everything. Okay, right. So let's look at. We started with the pregnancy journey. So how to diagnose pregnancy with all the signs, the different classes. Then we also looked at uh, maternal obstetric history. Okay, last week where we did the GT PAL system. So today we're gonna look at, and also we did fundal heighting. So today let's look at maternal weight. Okay, then gradually we finish the slide, then we move to another topic. Okay, so we are still collecting our data with our pregnant woman. So maternal weight changes. It is believed that the normal maternal weight gain in a single pregnancy, every woman or majority of the woman on the average, the total expected weight gain should be what 25 to 35 pounds or 11 to 16 kg for women with normal pre-pregnancy BMI. Normal pre-pregnancy BMI. So if someone has a normal BMI, which we know how to present it, we know how to calculate it on this page. Okay. So if you have a normal BMI and you get pregnant, it is expected that within the full pregnancy, you should at least add on weight. That is 11 to 16 kg for women with normal pregnancy BMI. Now let's look at the weight changes by trimester. Okay, so the first trimester, it is expected that every pregnant woman should gain 1 to 4 pounds in total. 1 to 4 pounds. Okay, a total.
Excuse me, please. I raised my hand, but you didn't see me. But the screen is not sharing, or I don't know what is from my side.
Oh, sorry. Am I not
Okay,
sharing
sorry.
it? Okay.
Okay.
Right. So can you see now?
Yes, sir. Yes, sir. It's not.
Okay. So I'm not going to record it because everything is going live. Okay. So I'm not going to record it. If you need the recordings, go to the live stream and watch it. Okay. Right. For those of you who are new here, we are also streaming at the same time on Facebook and YouTube. So you can watch it there. The videos are there. You can go back and watch it over and over. Okay. And take notes. Then it is something we are doing to help everyone. So once you gain access to this platform, then you also share the link to people to also join so that they also gain the same benefit. Okay, right. So we started with maternal health, like I was saying, maternal health last week, and we did the diagnosis the positive, the probable, and all those other signs. We did the fundal heighting. We did the GT piling, okay, GT pile system. So today we are looking at the weight gain. So I was saying that every pregnant woman, okay, should gain, is expected, if you have a normal BMI before you got pregnant, you had a normal BMI, it is expected that you gain at least 25 to 35 uh, pounds of weight. Okay, so we are taking it trimester by trimester. So the first trimester, you are expected to gain 1 to 4 pounds in total. You so the woman may have no gain or slight loss due to nausea and vomiting. Yes, so there are some pregnant women within the first trimester. Some of them will be having all this hyperemesis gravidarum, okay, or vomiting and all those stuffs. So some may gain, some may not gain. It's normal. Okay. Minimal weight gain in the first trimester is normal. It's normal. So pregnancy journey is ongoing. Let's look at the second trimester. So the second
Sorry,
trimester is, yes,
please, how do you convert from the pounds to the kg?
is 2.2. Okay, so the pound is always higher than the kg. Okay, so
Okay.
pound is always higher and kg is less. Okay, so if you want to convert, divide pounds to kg, divide by 2.2. Okay, then you get your kg. But if you get your kg in kilogram, so kilogram is pounds over 2.2, then if you want to, like the mathematics, we cross multiply. So 2.2 times kg is equal to 1 pound. So it's a universal formula. So look at your weight, anybody, your patient's weight, then you convert, right? Now, if you join, then you mute yourself, please. Okay. Right. So, and the second trimester, we are looking at this weight in approximation. Okay. So every week, every week, every week, every week, you are expected to gain what? 1 pound. 1 pound. Every week, you are expected to, in the second trimester, okay, every week, you are expected to gain what? 1 pound. So in total, we are looking at 12 to 14 pounds. 12 to 14 pounds in total. So by 14 or by 13 to 27th week, you are expected to gain this amount of. Why? Because in this phase, in the second trimester phase, the baby is rapidly growing. The blood volume of the mother is also increasing, and the placenta too is developing. Okay, so all these three factors, baby carries weight, the volume of the mother is expected to increase so that it will cater for the mother herself and the child herself. Then the placenta being the connection, the life support or the ventilator between the mother and the child, okay, for communication is also supposed to develop. So all these ones carries weight and it's going to take some weeks. So every week you are expected to gain what? 1 pound. Now let's look at the third trimester. The same thing for the third trimester. Okay. Every week you are supposed to gain 1 pound. Every
Calculation
week you are
ayɛ nti
supposed
wɔ yɛ
1 pound. Okay. Yeah. So the thing when it comes to weighting of or weighing of mothers. The only difference is that for second trimester and for third trimester, every week mothers are supposed to gain 1 pound. The only differential is that for the first trimester, we don't do it weekly. We look at the total span of the first trimester. So that is 1 to what? 4 pounds in total. 1 to 4 pounds in total. Okay. So let me show you the trick here. If you don't want to forget, how many weeks makes 3? How do we call it? How many weeks can we find in 3 months? Ellen,
12 weeks.
12 weeks. Okay. So always when you get so every first trimester is expected to last for 12 weeks. Okay, 12 weeks. Yes. So every trimester is sorry, every first trimester is 12 weeks. Okay. How many trimesters do we have?
3.
How many trimesters do we have for a pregnant woman to be pregnant?
3.
3. Okay. So always divide the 12 by 3. What is the answer?
4.
4.
Yes. So every pregnant woman, the first trimester should at most 1 to 4 pounds in total. Okay. You convert, if you want to do kilograms, fine. You do the 2 times 2.2. Okay. So the only difference is the first trimester. Okay. You remember this formula, never forget it for the rest of your life. We don't learn for examination, we learn to keep it. Okay. So always, every first trimester is 3 months. Okay. Then because we are dealing with weeks, convert the 3 months to weeks, you get 12 weeks. If you get 12 weeks, ask yourself, how many in the span of pregnancy from 0 day to the day you give birth, how many trimesters are we looking at? 3 trimesters. Okay. So the answer 12 you had divided by the 3 trimesters. That is the weighting of. If you get this one, you are done. Second trimester, every week is what? 1 week approximately, or equivalent to 1 pound. Third trimester, 1 week approximately 1 pound. You are done. If you know these ones, any pregnant woman who sits in front of you, it's going to be something cheap for you to be able to. Okay. So in the third trimester too, baby is still growing, maternal fat increases and fluid stores also what increases. So it contributes to what? At this stage, a lot of women will experience what? Uh, pregnancy-induced hypertension disorders. Okay. Yes, some because of the weighting, because of the fat, because of the fluid accumulation, and also placenta irregularities. Most women experience what preeclampsia. Okay, yes, but remember, sudden weight gain. Sudden weight gain. So, you are in maybe third trimester. So you are in maybe 30 weeks. Okay. You were 30 weeks old. You came to the clinic and you were weighing, let's say, 75 kg or 75 pounds. Okay. Then we tell you that, oh, come the following week. So you came at the 31st week. 31st week, if we weigh you, we are expecting to get at least +1. Okay. So 76 pounds or whatever. Okay. Now you came the same week, you came and you are 88. Look at the gap. Where did you gain this weight from within this 1 week? Okay, we will start thinking about what preeclampsia, preeclampsia, preeclampsia. So in this case, focus on the blood pressure, the proteins in the urine, and all those factors. Okay, yeah. So let's look at the summary table. Here is it. Those of you who likes to get things so easy and simple, these are the summary tables. First trimester, you know how to calculate it. Now, the second trimester and the third trimester, this is how we're going. Okay. Now let's look at irregularities that comes with so abnormal weighting. Okay. So excessive or rapid weight gain. For second or third trimester, every week you are getting 2 pounds and over. 2 pounds and over abnormalities, abnormal weight gains. Okay, you are getting 2 pounds and over. We will open our eyes for you. We will keep watching you, become more vigilant on you. Okay, so especially with facial or hand edema, headaches, you are increasing weight with all these signs and symptoms, headaches, visual changes. We will think about what preeclampsia. Okay, so that is when you are gaining more. Let's look at the opposite side. When you are not gaining, inadequate weight gain or less than expected. So you are in, let's say you are 20 kg, okay, or 20 pounds. The next week you were expected to be 21. Okay, but you rather came and you are hot. In second and third trimester, you rather came and you are 18 pounds. Where within this 1 week, okay, where did the weight pass? Where did it vanish to? Okay, is it the baby that is not growing? Because we are looking at three things now. We are looking at the maternal fat, the placenta weight, the baby's weight, and the blood volume of the mother. Okay, so these are the areas we focus on. Let's look at the baby. Is the baby not increasing weight? What is wrong with our placenta? What is wrong with our mother? Okay, the mother's blood volume and all those stuff. So intrauterine growth retardation, preterm birth, and low birth weight. People don't eat, okay, so that their babies will not become big. So all these things are there. So the memory trick says the little steady, steady. A little steady, steady. That is how the first trimester, a little increment. Second trimester, we go steady. And the third trimester, we go steady weight gain. Okay. Second trimester, third trimester, when your weight starts increasing abnormally, okay, we start becoming more vigilant of you. Okay. So the first trimester, we have a little weight increment, that's fine. The second and third trimester, we are looking at a steady weight gain. So at least 1 pound every week. Perfect. You can go 2, but don't go more than 2. Okay. Now let's look at the perinatal care. Any questions so far? Any questions so far? The perinatal care. Okay. So the perinatal care now, we are still having our pregnant woman. Okay. So we are taking care of her, the family, and all those stuffs. So when we say perinatal, we are looking at the antenatal aspect of it, the intra and the postnatal. Okay. So the antepartum or the prenatal.
Hey,
Yes.
I'm sorry, but I have a question.
Okay.
The weight gain, is there any restriction for mothers who have abnormal weight prior to pregnancy, like for obese and then underweight women?
Oh, yes. So we were talking about the BMI aspect. Okay. These ones, mm, these ones mostly work for people with normal BMI before pregnancy, but overweight and all those, yes, they are going to increase. This one works for everyone, but people, if you want it more accurate, you will find it in people who were having normal BMI before pregnancy. But people who were having abnormal, morbidly obese and all those people, yes, they will increase, but their increment is mostly more than what those people with. So we don't, it's not like we will restrict their weight. People who are sometimes morbidly obese and all those stuffs, it's not their fault. Okay. Yeah, some of them, that is their gene, that is their DNA. Okay. No matter what, even if they don't eat, they become fat. Mm. So those people can come that, but we have to keep eyes on them. Keep eyes on them because of the pregnancy induced hypertensions and all those other factors. So you keep eyes on them more. Okay. So it's not like we are going to restrict those people. We don't have anything like weight restrictions. Okay, strictly for these guys. Okay. Yeah. Is there any question?
Yes,
Yeah.
please, can you come again with regards to the expected weight for the first trimester?
The first trimester, I've told you that we have 3 months in first trimester. Okay. 3 months in second trimester and 3 months in third trimester. So now let's convert the months to weeks. We have 12 weeks. 12 weeks. 12 weeks. Okay. Making 36 plus 1. Okay. So now let's take the first trimester because our focus is on the first trimester. So let's take the first trimester. The weeks is what? 12 weeks. 12 weeks. Divide by how many trimesters do we have in total in pregnancy? 1, 2, and 3. Divide by 3, you get what? 4 pounds. Weight. You get 4 pounds. Yes. So any pregnant woman who was having BMI, that is normal before she got pregnant, is expected to have what? For the first 12 weeks, is expected to have 1 to 4 pounds. Okay. Pata pata. Or last 4 pounds. Okay. In the whole of the 12 weeks. For the second and the third trimester, you don't have to worry your head. Every week, we have 12 weeks. So every 1 week is 1 pound. Every 1 week is 1 pound. That's it. You are done. But do you understand?
Yes, thank you.
Now let's look at the antepartum or the prenatal care that we are going to give to this patient. We are still having our pregnant woman. Okay. So the initial visits. This woman comes. What are you going to look at? The initial visits. What are some of the assessment? What are the things you're going to do for as a health worker? Okay. The pregnancy test is very important. Okay. You need to test the urine. Then you also need to test the serum ACG. Why do we do that? Who can tell me? Ellen, why should I test the serum ACG and also the urine ACG?
To confirm the pregnancy.
Come again.
To confirm the pregnancy.
Yeah, to confirm, yes, to confirm. And also what? To confirm pregnancy, that is one. And what? Do we only use it to confirm pregnancy?
I think to rule out molar pregnancy too.
Okay, yes, to rule out molar pregnancy. So mostly this human chorionic gonadotrophin, it increases as pregnancy ages. Okay, so the day you got pregnant, this hormone will start increasing. And they will increase, they will increase, they will increase. Okay. So if I come and test your HCG level and today it is 1, then I tell you go 2 weeks time, come and I test again and it is still 1. Okay. Then I'll be like, are you really pregnant? Because by 2 weeks time for you to come, I should be expecting like say 20 or 30 or whichever amount, hundreds. It should go, it should be increasing. It's a hormone. Okay. Yes. So I should be seeing this in the blood and in the urine. I've told you that whatever you see in the urine is coming from the blood. Okay. So the blood type and the resource factor is very important. The ROGAM, mostly at week 28 and postpartum, if baby is resource positive. Okay. So we have the resource. Remember, resource. We have the resource. Resource. This one, do you know it came from a specific type of monkeys? If you Google it, or if you want to read more about it, but today we are not going to that angle. Okay. There are specific proteins found in the red blood cells of certain monkeys, certain species of monkeys. Okay. Yes. So mysteriously, we have some human beings too who are having what this resource on their red blood cells. Okay. So what does it do? It is, ideally every red blood cell should not have any resource. It should not have any cross like this. It should be like every red blood cell should be like this. It should not have this proteins. They are called proteins, okay, on top of it. But a mother can have a normal red blood cell, and a father can have what? A red blood cell with this type of protein on it. And it's not your fault, okay? It's not your fault that you have plus that protein on top of your red blood cell. Okay. But the fact that it's not your fault does not mean that you should what? You should not keep your eyes on it. Okay. So this woman and this man had a baby. and the baby is going to stay inside the womb of this mother. So it is going to be something like this. Okay, the mother had this is the womb. So this woman has this baby inside, but the baby is having what? This positive on top of the red blood cell. Where did the baby get this positive from? From the father. Okay, the father. Okay, but this woman doesn't have anything. And these two guys, in resource factor, positive and negative do not meet. They hate each other. They are big enemies. Okay. Yes, they are incompatible. Okay, they are incompatible. They cannot be companions. That is the English. They are incompatible. Okay. So this pregnant woman is carrying this baby. In between this baby and this pregnant woman is a life support. Me, I've stopped calling it placenta. I call it what? A life support. Okay. If you want to go deeper into physiology, you realize that the placenta that is embedded on the uterus of the mother. And so this junction and the umbilical cord, okay, is going to the baby. And this is what the mother's, okay. So whatever comes here, they don't just cross, they diffuse. They use the power of diffusion. They diffuse, okay, to the mother, and the same way in that angle, they diffuse. So they don't mix. The blood do not mix. Okay. It is a very tight security here. They don't mix. Okay. If something happens and this place breaks, how can it break? Is it trauma to the uterus? Okay. Is it accident or what? Is it that this baby was being born? So this protection will go on till childbirth. And when we give birth to this baby, the placenta will be like, so it's like it's like you having some bad substance and you smuggled it through immigration. And later, immigration will detect. When they detect anybody who comes after you, they are going to scrutinize that person. Okay. So this baby was born. Baby is out now. But in birthing, okay, no matter what, these two guys are going to mix blood in birthing. Okay. Whether the vaginal delivery, whether yes, they are going to mix blood. And the moment these red blood cells enter into the bloodstream of the mother. Remember, we did lymphatics. Okay. So the lymphatic system will pick it up. Okay. Yes. So they will pick it up and they will send signals for the production of antibodies. Ellen, which part of the lymphatics will pick it up? We have the roaming lymphatics and we have the stationary lymphatics. Do you remember? If you don't remember, let me continue. So we have the T lymphocyte and the B lymphocytes. Okay. So the B lymphocyte, always look at the bone marrow. The bone marrow is always stationed. The bone marrow does not travel, but the T is traveling. Okay. The bone marrow is always at one place, but they travel and the T, they are roaming in the body and they are scanning the body. So if you eat anything, if any bad substance enters into you, okay, they will send signal. These guys will detect it and they will send signal to the B lymphocytes. And the B lymphocytes are going to produce what? Backup. In military, we call it what? More military backup. They are going to produce backup cells to come, or reinforcement. So they will come with what? That energy and strength. We call them what? Antibodies. Okay. So these antibodies will come and fight this guy, these positive red blood cells, destroy it. Then after fighting it, they will make a law in the system of the woman that henceforth any substance that is carrying this type of protein on top of it, when the body detects it, immediately damage. They should damage it. They should destroy it immediately. Okay, so they will destroy it. I hope you are following the story I'm telling you. So future pregnancies. Remember, the husband and the wife, they've not divorced. And they are not satisfied with one baby because they want to give birth more. Okay. So they will go and meet again and produce another baby again. And because this father is having the positive sign, if this baby pick up what the pick up the genetic of the mom, okay, and does not have any proteins on top of his red blood cell, you have a successful pregnancy. But if this baby picks up what the proteins from the father and it represents itself and goes inside the uterus of the mother, sudden attack. These antibodies will not even respect the placenta again. They will not respect this barrier. They will destroy the baby. They will kill it and destroy it, cause miscarriage under 20 weeks. Okay, under 20 weeks. So what did we do? We sat down, or scientists sat down and said that no, somebody gave birth, one. Any subsequent birth, less than 20 weeks, miscarriage. Less than 20, the person has tried like 4 times, miscarriage. Okay, let us do something. Let us create a certain medication that we will give to this woman, okay, or any other woman that is having this, okay. That when the woman is pregnant, on the 28th week, let us give that medication. You give me, so that medication will go and negotiate with the lymphatics that, hey, a baby is coming, and the baby is positive. Okay, it has positive proteins on top of the red blood cells. But you know what? They are doing the negotiation. But you know what? Yes, I understand that you people don't like anything positive in your system. But I beg you, this one is my own. Just keep it for me. Okay, don't attack it. Keep it. Okay, so they will salute. It doesn't end there. So in the course of the pregnancy, they what? 28 week, you give the rogam. Okay, this is 0 week, 28 week, and birthing. Okay, so you give it. So when you give it, this is what to tell the mother system that a baby is on the way coming. Okay, the baby is making a journey to 37 weeks. That baby is only 27 weeks. But the baby is having what? Proteins that you, the mother, doesn't like. But hey, I want to be an intermediary. I want to intercede that whatever happens, okay, or if this baby comes, don't attack the baby. Leave the baby, okay? Yes, we want to create life. Don't kill the baby, okay? Then the lymphocytes of the mother will say, okay, salute, we understand. Now, the pregnancy will be going on, ongoing, progressing. Then after birth, after birth too, we will also give, okay, because during birth, we will have plenty of mixture of blood between the mother and the child, mother and the child. So we give another rogam. So when we give the rogam, it is to confirm what this guy started. That hey, now the baby is out. Yes, I know. He left a lot of proteins, bad proteins for you. Don't worry. Okay. Let me give another one to neutralize the system. So any future pregnancy that comes, the mother's red blood cell will not attack it, or the mother's lymphatic system will not attack it. So that is all about what the resource factors. The resource factors. There are a lot of people. I'll do a short video on this. Okay. Or I'll prepare a video. Yeah, Victor.
Yes, sir. If my mind can tell me, I mean that this program, when you are giving at once for one pregnancy, that's all.
Yeah. Ellen explain to him.
Yes, it's given once. So that means that if you are a little girl and you don't know your resource and you have an abortion, that means you're not going to be able to conceive for the rest of your life.
Yes, it is. That is another challenge people are having now. I was going to talk about that. Okay. I was going to talk about that because when we were young, we dated a lot of people, especially the ladies. They dated guys were always worrying them. Hey, I want to be your boyfriend. I want to be this. I want that. I want to sleep. When they started the journey of relationship, okay, pregnancy came in, abortion. You are not ready to deliver. Okay, you are not ready to take care of a baby. So abortion came in. Okay. Now, there is no way. The problem is the birthing. The birthing that a baby is coming out. Okay. This is a baby coming out of the uterus of a mother. In this process, no matter what, blood will mix. Blood will mix. That is where the problem started from. A lot of women are walking on earth within this short phase of physiology. Their lives have been changed and they are struggling to give birth today. Okay. Yes. They are struggling to give birth today. Why? Because that resource positive, that proteins entered the mother's bloodstream, the woman. It enters them, and their system has generated what? Some serious antibodies against future pregnancies. People are having, but research and advancements are ongoing. So, I mean, nowadays people can even do, okay, a whole lot of technological advancement is ongoing. So, no matter what, somebody can even carry your pregnancy for you. So it's normal. Okay. Yes, it's normal. So Is that Victor? Are you okay with that? So
Yes, sir.
in the
Thank you very much.
antepartum assessment, we are looking at CBC, complete blood count, HB, mostly what should be what more than 11. Then we have the rubella immunity, is very important. Antepartum, the rubella immunity, the HIV screening. A baby is coming out, an innocent baby. So this baby should be secured from any rubella infections, should be secured from any STIs. So syphilis, chlamydia, gonorrhea, all those ones. Okay. Hepatitis, very important. The baby should be protected from that. Okay. Then we also look at the protein and the glucose aspect of the woman. These are big molecules that are not supposed to pass through the glomerulus of the woman's kidneys. Okay. So when we see a lot of proteins and glucose in the urine of this woman, what is happening? Why is it that bigger molecules are passing through the glomerulus? They are going to cause damage to the glomerulus over time. So a lot of women will deliver and they have kidney issues, or these same two guys can be an indicator of what? Preeclampsia, okay, or pregnancy-induced hypertension. So all these things are, you do all these clinical assessments in your antepartum stage or visit. Let's look at the routine what care, prenatal care, okay, by trimester. So first trimester, we call it the organogenesis, organo, mm, organogenesis. Genesis is the beginning, and organ. So the body organs, that is the beginning of their formation and growth. Okay. So we have so many organs in the body. They start their journey from what? The first trimester. They are all full of cells. In this world, if you want to get plenty cells, or your cells to be well nourished and more strengthened, okay, what do you take? You take a certain medication or vitamin. We call it what? Folic acid. Okay. So you realize that a pregnant woman comes to the clinic, they will prescribe folic acid in the first 12 weeks or the first 3 months of pregnancy. Okay. This mother will go home and will not take the folic acid. You are not taking the folic acid because of you. Ellen is 50 years. Ellen is pregnant. If Ellen takes folic acid, what will folic acid do to Ellen's body? Ellen's organs are already developed. So what is she going to use the folic acid for? This baby inside Ellen, who is now developing organs, need what? Folic acid to what? To develop, to grow. Okay. Yes. So you, the mother, the baseline of whatever I'm saying is that you, the mother, you don't take the folic acid for yourself. You take it for the baby. So anytime you give them folic acid, the midwives who are watching me, anytime you give folic acid, this is the advice you should give to the mothers. Okay. Then we have the nausea and the vomiting management. People have a whole lot of issues. Okay. Vomiting and nausea. Okay. Yeah. So what do we do? Dry carbohydrates, crackers, biscuits, and all those stuffs to help solve. And severe warning signs, severe vomiting or bleeding and abdominal pains. So you do all these clinical assessments the first trimester. Second trimester, baby is still growing. So fundal height is our concern. Remember, we said that 20 weeks and above, fundal heighten. Because after 20 weeks, we have entered where? Victor, after 20 weeks, we are no more at the abortion phase. We are where?
We are in the preterm.
The preterm. Okay. So from the beginning of the preterm to term, whatever, birthing, fundal height is very important to us. Fundal height. Okay. So weeks, every week you do your plus or minus 2 centimeters. Okay. Then the quickening is 16. So in the abortion phase, 0 to 19 weeks. Okay. We will look at what baby should move. Baby should move. Baby should, 16 to 19 or 20. Baby should move. So we have phases. We have 16. I always add 2 plus 2. So that is 18 plus 2, 20. Okay. By 16th week, you should begin to hear. That is the beginning of quickening. This one, quickening. Baby is moving. Okay. By 18 week, that is the peak. So it goes like this. It starts from 0 point, goes high, then descends down. And okay. So this is the peak of quickening by 18 weeks. Okay. By 20 weeks, if you don't hear your baby, we need to do some ultrasound. That baby is dead or what? What is going on? That you can't hear or you can't feel your baby. Okay. Yeah. So all these ones, okay. 1 hour GTT at 24 to 28 weeks. All these ones are the assessments we do. Now let's look at the third trimester. At this stage, we are preparing for birthing. Okay. We are getting ready for birthing. So we look at what the kick counts. Okay. The kick count, especially when you are nearing labor and all those stuffs. Okay. 10 movements in every 2 hours. 10 movements in every 2 hours. Can you count the kicks of your baby? Baby is inside you, kicking you, king. Okay. Yes. Then we do the swaps. Okay. We do all to do our screening and all those stuffs. So by 30th to the 7th week, this is where everything should go. Now, danger signs, the low or reduced fetal movement in this stage. What is happening? Is it fetal distress? Or what? Baby is overly moving. Are they in distress or what? Is there a cord around their neck that is strangulating them, choking them? Okay. The uterus of the mother and the pelvis of the mother and the size and weight of the baby. So all these ones what affects the health of the baby. Headaches, the baby cannot say I have headache, but the mother can say I have headache. So headaches, right upper quadrant pain, and all these issues. So headaches is what the pregnancy-induced hypertension, PIH. Right upper quadrant pain. Okay, that is where the liver is getting involved and all these syndromes comes in. Visual changes, okay, still related to the PIH. So you see it more. Okay, mostly pregnancy-induced hypertensions, it starts coming up from 20, when you enter the preterm, 20 weeks and above. Okay. If you start getting PIH in 20 weeks, you will have from 20 weeks to 37 weeks. Can you maintain the hypertension in a normal state? So you give birth. If you start seeing +1, +2 proteins by 20 weeks, if you are not careful, this pregnancy will not end. It will terminate on the way. Okay. And if you are not careful, you will get eclampsia. So you keep eyes on them. After 20 weeks, when hypertension starts setting, that is why a pregnant woman, we are always concerned about the weight of the pregnant woman. The weight. Of the pregnant woman. You are always concerned about the weight of the pregnant woman. It's very, very, very important to know. Okay, right. So let's look at the antepartum danger signs. Vaginal bleeding, severe headache, blurred vision, swelling of the face or hands, the sudden gush or leaking fluid. That is premature rupture of the membranes. Okay, yes, I want to talk about this because the rest are all similar or familiar symptoms. Okay, so premature, this is the uterus of the baby. This is the baby, the uterus of the mother, and this is the baby. And there is a covering around the baby. Okay, what is the name of this covering? Victor.
Amniotic
Yeah,
sac.
please, I'll fire from the PC. Sorry.
Somebody said the amniotic. Amniotic what?
Fluid.
Yes, inside this is the fluid, but the whole of this is called what?
The amniotic sac.
Amniotic. Okay. It serves as a cushion for nutrients and also exchange of food, waste products and all those stuffs. Okay. Right. If this one punches, something punches it and the fluid begins to leak, sometimes it gush. Fetch water into a balloon and punch it with a big knife. The water will gush. Okay. Fetch water, the same balloon, or fetch water into it and puncture it with a small needle. The fluid will leak. This is what is happening. When it starts leaking, what will happen to the baby? The baby is exposed. This is serving as a barrier between whatever is going on in the uterus of the mother. If there is any infection, all the infection, the swabs and all those stuff, the STIs, the syphilis, the gonorrhea, everything. See, infections will climb up, enter into the uterus. Okay. Then this one will serve as a barrier. But now there is a hole. So the infection can cross and go to the child and affect the child. Temperatures inside, everything will be affecting this child. So this child will get what we call what? Without distress. So we are always careful. somebody is pregnant 32 weeks. The membranes have ruptured. The amniotic sac has burst. This woman is going to has how many weeks? 5 weeks more, 37 weeks. Okay. Can you watch this woman to be walking around with no protection for the baby? No, the baby will be infected. So, Ellen, what do we give them? If this situation happens on the ward, what is the prophylaxis? Yes.
Antibiotics.
Antibiotics. The ABS guys. Okay, and the fluids. So antibiotics. Create an infection barrier. Create a barrier to protect the baby. Antibiotics. Very important. Okay. Yeah, very, very important. You should take note of that. Okay, we already know fever and chills as a sign of infection get entering into the bloodstream. Then decreased fetal movement means the baby is compromised. Okay, so take note. Take note of that. Now let's go to the intrapartum care. The intra. So we are going to look at what? Yes, Bewin. Shoot.
I want to know with the prom, I've had a lecture discussion on one of my clinical meetings where they made mention that with the steroid like dexamethasone is very important when you are managing prom. I don't know if that is also okay to be added to the medications that will be given at that time.
Yes, you need dexamethasone. Dexamethasone is very good with infections. Okay, one. And it also, you can give it to help the baby's lungs to mature, because inside the lungs, a mature lungs have what we call surfactant. So this is your lung. There is a certain chemical here that is inside here. We call it surfactant. The more your lungs mature, goes up, the more the surfactant increases. What is this surfactant? Surfactant will create a surface area so that any oxygen that is coming from the atmosphere, when it gets here, it can easily cross to the pulmonary system. And any carbon dioxide that is coming out, when it gets here, it will cross. So look, let me tell you surfactant. Have you seen, are you a soccer fan, football player?
Yes,
football player.
Yes.
Yes. Okay. So footballers, they play on what? A football field. Okay. Imagine 11 players plus 11 players making 22 players. Okay. Plus all their supporters, fans. Plus all their coaches and all these technical team. They will go to the football field. Okay. To play match. What will happen if the football field is too small? It's too small. The team doesn't have money. So their football stadium or the field is too small. Okay. What will happen? They cannot play the ball for them to be comfortable. There's going to be congestion. There's going to be stampede. I mean, chaos. So there's going to be chaos. Okay. So a lung that is not matured, we don't have enough surfactant. So oxygen will come here, it cannot cross. Carbon dioxide will come here, it cannot go out. So everything will be stuck here. And what will happen if baby is not getting oxygen in the bloodstream? It will cause what? Baby will desaturate. Okay, yes, baby will desaturate. But these football players now, they have money. The team has money. They go and build a big stadium. Okay, the big park, nice one. Everybody will be comfortable. So the more the lungs grows, the more the surfactants. What helps the surfactants to what? To grow or to mature? We have what we call the steroids. The steroids. The steroids. So a baby or a mother with what premature rupture of membrane at this stage, the next thing we are expecting is uterine contraction. And if the uterus contracts, the next thing we are expecting is what baby should come out, expulsion. If this baby is coming out at the age of 32 weeks, do they have enough surfactant? No. So steroid is very important. At the same time, so that is one aspect of the steroids. The other aspect of the steroid is what? When infection gets into the bloodstream, they cause, so if this is the blood vessel, every blood vessel has what? Capillaries. How do we call it? Membranes. Like this. This membrane is semi-permeable. So what does it do? These cell membranes will prevent the blood plasma, the water part of blood, from leaking into what? The interstitials. Because once fluid gets into the interstitials, you'll be edematous. So if you are edematous, what happens to your blood volume? The blood volume will reduce. And if it reduces, what is the condition? Hypotension. Yes, when we look at you, you are swollen, big, like somebody with nephrotic syndrome, all these kind of liver issues and kidney issues. The fluid is shifting from the bloodstreams to the interstitials. Okay, so you see them, either edema and all those things, moon phase and fluid has shifted. But in their bloodstream, they will be having what? Hypovolemia. So why will infection do this? Infection will come and traumatize these cell membranes and the inner lining of the cells. So once there is injury, the next thing is inflammation. And when the cell membranes are inflamed, they will give space, they will open up. So it will be like something like this. The cell membrane will open up, big space in between them. Big space in between them. And this is so what will happen to the plasma? The plasma can easily leak out. Leak out. Leak out. Leak out. So the steroid will come and what? Reduce the inflammation. It will reduce the inflammation. Remember, asthmatics and steroids, they will reduce the inflammation. So a typical example of our daily life is I have what? A metal. If I put the metal or I put the metal in fire, what happens? The metal expand. So whenever there is injury, there is expansion, inflammation. But when I put the same metal in water again, it closes. Okay, that is what the steroid does. So premature rupture of membrane, you need steroids, very, very important. Infection too, you need steroids, very, very important. Okay, so when you do the sepsis protocol, you understand all these things. And let's look at the intrapartum. So the intrapartum, every pregnant woman will walk to the labor room that I am observing what contraction or labor. So the midwives are trained, they are professionals, they are trained to differentiate between a true labor and a false labor. They are trained to differentiate between a true labor and a false labor. So what are the signs or what are the characteristics of a true labor? Yes, there should be contraction, one. But are the contractions regular? Are the contractions regular? So this is contraction. It has occurred on the 0 minute. Then maybe 10 minutes time, another contraction will come. Okay, so this is 10 minutes. Then 10 minutes time, another contraction, that is 20. 10 minutes time, another contraction, 30. So what is the differences? You realize that every 10 minutes, you observe contraction. Every 10 minutes. If the time is shortening to 5 minutes, every 5 minutes, you observe contraction. Every 5 minutes, you observe contraction. It will not be like here is 5. The other time is 30 minutes. The next time is 15 minutes. This one is called irregularity of contractions. So it makes it a false contraction. But genuine contraction, proper contraction should be regular. Okay. As the contraction is progressing, moving from the 0 to the 30, as they are moving from here to here, their intensity, their strength, their pain, their its ability to be more critical increases. Okay, so here you are having what maybe small pain. Then here, moderate pain. It means pain has what increased or pressure. Okay. Then here, severe pain that you can't even stand, you can't do anything. That is what the increase in strength, the energy. Okay. Yes, the increase. Now let's look at the mouth of the uterus. This is the uterus. The mouth of the uterus is called cervix. Cervix. Okay. So cervix, the mouth of the uterus is cervix. If the muscles of the uterus are contracting, they will be like this. So when they contract from the top to the down, its contraction moves top to down and across the muscles. Okay. So they move down, they push the baby down. When they push the baby down, the head of the baby will gradually enter into the pelvis. And the bones will open up. When the bones open up, all the ligament and everything will follow it. And it will open the cervix, the mouth of the uterus. Okay, so that's what we call cervical dilatation. And you are going to dilate from so and so, whatever, to 10 cm. 10 centimeters, full dilatation. Okay. Then the pain radiates. So with all this intensity and everything, now the pain will not be at the lower abdomen or the abdomen again. It is now radiating to the back. Okay. Because all these pelvis, all these ligaments, all these muscles here, it's a communication, it's a network of activity. Okay. So the baby's head is descending down. So the pain, more pressure on the pelvis, and pain will radiate from the front to the back. Okay. Yes, we call it what? Pain radiation to the back. And contraction does not stop even when you rest. Yes. When you rest, the pain does not stop even when you rest. Sorry, the contraction does not stop when you rest. It means what? This is a proof. Let's look at the fourth one. Somebody can come. I have contraction. Okay, let us measure your contraction. We measure. They are not regular. The time interval is no. Intensity. Intensity. Okay, today or at this moment, your pain is so high, pressure is high. The next 10 minutes, Mommy, how are you? I'm fine. Everything is fine. Drinking cocoa and everything, not cursing their husbands. Then the next time the
Hey,
pain
we
will
have
jump
stopped
again.
that. We have stopped that.
Yes. So all this is not regular. So sometimes there is no change in intensity. Cervical dilatation, there is no dilatation. And pain radiating to the back. Over here, it is only the abdomen. Okay. It is only the abdomen. Because it's a false labor, no child is coming down, descending down. So the pain is concentrated only on the abdomen. The pelvis are not involved. And when we ask this woman to go and rest, you go and find her snoring. The pain is gone, contraction and nothing is happening. Okay. So that should tell you that, anyway. Oh yeah, look. Okay. Right. So the stages of labor. We have the stage one. We have 20 minutes to leave online. Okay. So stages of labor. We have the stage one, stage two, and whatever. Okay. So stage one is the cervical dilatation phase. The 0 to 10 centimeters. For your cervix, the mouth of the uterus, this mouth of the uterus, the cervix, for it to dilate from 0 to 10, so many things happen. We need the muscle to contract. And if they are contracting, it should be a force, it should be a positive contraction, meaning a positive labor. So if it is a positive labor, it means contraction should be regular, like we saw it here. It should be regular. Okay. Cervical dilatation should be perfect, systematic, moving from this stage to, okay. Yes. So all these ones. So these stages is further divided into 3. 1, 2, and 3. Okay. The cervical dilatation. So we have the 0 to 3 centimeters. 0 to 3 centimeters. Then we have the 4 to 7 centimeters. Then we have the 8 to what? 10 centimeters. Okay, so this is the trick. Those of you who are going to write NCLEX would like to bring these ones, test people on this. Okay, so this is the trick. Always ask yourself 0 to 10. Okay. 0 to 10. Cervical full dilatation. Okay. So multiples of 3. Multiples of 3. Every pregnancy has what? 3 trimesters. Okay. 3 trimesters. Okay. So start with your 3. That is the first stage. This phase is divided into 3. We have the latency, the active, and the transition. So we have an acronym we call the LAT. You can write it down, the LAT. Okay. So if pregnancy, maternal health is multiples of like 3. Okay. 3 number factors. 3. We use 3 to do so many things in pregnancy. Okay. The number 3. So if I have 0 to 3, that is the first one, the latency. From 3, after the number 3, I'm counting from 0 to 10, but I am now at 3 centimeters. From the number 3, where do you go? It's not 4. Victor, it's not 4. When you move to 4,
Yes, sir. 4.
that is, yes. When you move to 4, go back to your trimesters, add 3 again. So 4 plus 3 is what? 7. So you've gotten what? Your active phase. Okay. Then from 7, you go to what? 8. But remember, your counting should end at 10, not 11. Have you got the trick? So instead of adding 3 for the transition phase to get 11, cervical dilatation ends at 10. So you should not go to 11, stay at 10. So I'm going over again. I said pregnancy is what? A multiples of 3 game. Multiples of 3. Multiples of 3. Multiples of 3. Okay. So always you are counting. Let me clear the screen. So 0, 1, 2, 3, 4, 5, 6, 7, 8, 9, and 10. So I want to divide this into the first stage of labor. That's the cervical. But I remember that pregnancy has 3 trimesters. 3. So pick any of the 3. Okay. So I'll come and stand here, meaning 0 to 3 is one phase. If I leave this phase, the next number I'm looking at is 4. That is here. So I've started a new phase. When you get the 4, add 3 to it. So 3 plus 4 is 7. So I'll get this number, meaning I have divided here. And automatically, this is my active phase. Okay. And the rest is what? The latency. You are done. So pregnancy, maternal health is okay. I love maternal health. It's a nice game. Yes. So if you have any pain medication, it goes in this phase. This is the active phase. Okay. If you have any pain medication like epidural and all those stuffs, okay, in the middle. Don't give epidural here. This is the flexing phase. Any pregnant woman in this phase is flexing. Okay. Once a while, they'll complain, Charlie, my ass, me, shoulder pain and all stuff. They can go out and go and buy porridge, drink, go to the market, do so many things. Okay. Chill. This is the flexing stage. Contraction happens once a while, then it happens again. It's regular, but it's not consistent. Like it's not, it doesn't occur so fast. Okay. Yes. And the intensity too is not high. So mother is chilling, enjoying life. Over here, they don't insult their husbands. Okay. In the active phase, the pain will be increasing. The time in the space between them, the contraction will be reducing. Okay. The pressure will be increasing. Over here, they are preparing for labor. They are preparing. So what do we do when a patient comes here and you do your cervical dilatation and it's between 4 to 7? The NCLEX will tell you, or your license, it will tell you that prepare for labor. Okay, prepare for labor. Yes. So preparation, epidurals will go in if the patient wants epidural. All those stuffs will go in. Okay. When they get here, the same contraction, now pain is super, super high. This patient is very restless. They don't pay attention to anything. Okay. The timing in between the contraction is very short. Now over here is even seconds, 60 to 90 seconds, seconds. Not even no flexing here, no pampering here. Over here, when they get here, what do we do? They say what? Labor is imminent. 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 So you have to deliver the baby. When the mother gets here. Okay. At this phase, baby should be on the delivery bed. Yes, that the midwife. Okay, let's look at the exams or your licensure, especially NCLEX will come again. The same 3 phases. This is the patient. Okay. In the latency phase, should the midwife be with her? No. Once a while, the midwife will come and check and go. Some of them, you even tell them to go home. Over here, yes, we will get them to get the epidurals and all those stuffs in. You will be coming to them, the midwife or the healthcare worker. You will be coming to them. Okay. But when they get here, should the midwife be with them? Yes. Should the midwife leave them? Here, the midwife comes and goes. Over here, he comes very often and also goes away. He doesn't stay with you forever. But in the transition phase, the midwife should be with you here and should never leave you. Never leave your patient in this phase. Never leave them. Because baby can come out. If baby is coming, complications can occur. They can be tearing, they can be bleeding. So pain is what? Okay. So that is the most important thing. Okay. Okay. So everything I've said is here in this table. If you look at the top here, these are the futures. So we have the latent, the active, and the transition. And here are the components. Okay. So cervical dilatation. I need to update this page. Contraction is mild, moderate, very strong frequency. The frequency is very important here. make these changes, okay? Make these changes. Then the duration, 30 to 45 seconds. Active phase, 45 to 60 seconds. Transition. So the duration, if contraction should start in the latency stage, within a short time, contraction has stopped. Then the woman will go and chill, go and bath, go and eat, go and pound fufu, make a bath, enjoy. Because contraction comes, but it doesn't stay long. Okay, so the contraction is short. Always take note of, we have contraction. The length of contraction. So there's one contraction here, one contraction here, one contraction here. Okay. So when this is like epilepsy or seizure, so the length, we always measure it the same, like the same measurement. So when seizure starts or when contraction starts, measure from the beginning of contraction to the end. Then you wait. This is what you wait for and see if you see another contraction or experience another contraction. Yes. How many minutes did you wait? Because we are in the latest, you waited for long. Some of them so many hours. Okay. Then another contraction will come. So this is what intercontraction resting period, or in short, this is the resting phase and the contraction phase. So always examinations will trick you with some of these things. It's not difficult, but they will always use English grammar to trick you. So always shine your eyes with your English, your grammar. They will use it to trick you. Yes. So the contraction itself, and after contraction, how long did the woman rested? So the good thing I want to teach you today is that let me use contraction as C and let me use resting as R. They are what? Inversely proportional. So as pregnancy or the first stage is progressing, as we are progressing from 0 centimeters to 10 centimeters, what happens? The contraction will be long. It will be long. Before it was very short. Contraction was short. And the space for the woman to rest was long. So they can go to market and come back. They can go to farm and come back. They can go and fetch water, prepare fufu for their husbands and children. Okay. Now, the active phase is progressing. Contraction rather becomes long. Okay. So longest. Long, longer, longest. So the latency phase is long. Okay. It's long here. Then in the active phase, it prolongs. When the contraction starts, it takes a long time for it to stop. And the woman does not rest for long. So the resting will be what? The inverse proportionality. Okay. Then the contraction in the transition phase, this one contraction will never stop till baby is out. And the woman will be cursing everybody in this world. Okay. Yes. They will be cursing everybody in this world. So Victor is laughing. So these are the things you should know. Okay. Now let's look at the maternal behavior. Here the woman is excited. Yes.
Please, with the previous slide, you said that the latent phase is from 0 to 3 centimeters. And the active phase is from 4 to 7.
Said
And then
make
the
changes here.
transition is 8 to 10. But here,
Make make changes.
okay.
I told you. I don't know if you did
Oh,
not hear.
okay.
Make changes. So make changes. Okay. 8 to 10. So make the changes. Okay. Right. So let's look at the behavior of the woman. In the latent state, this woman is excited. They can go for party, do everything. They are very talkative over here. In the active phase, they become serious and focused. Pain is increasing, pressure is increasing. Pain is radiating from the front to the back. Then over here, they are no more serious and focused again. They are irritable. Everything angers them. Anxious, out of control. They will insult everybody, insult health workers. So if you are a health worker, you should know that it's not them. Physiology can make you lose your temper. Okay. Yes. They're not all women. Yes. So the pain level also increases. These are I've made it so simple and easy for you. I don't think, but remember, no contraction on earth should cross 90 seconds. This is one key. No woman, yes, no two pregnancies are the same, but no woman on earth should have contraction that will stay on. Contraction will start. If this is contraction, if contraction start and you start timing it, it should not cross 90 seconds. Because the contraction is the uterus. The uterus has muscles. It's the muscle that is contracting. So if the muscle contract consistently over 90 seconds and does not rest, what will happen? It will rupture. If it ruptures, a lot of bleeding. Baby will drain, some mother will lose blood and die if you are not careful. Okay. Yes. So these are the things you should know. Okay. Your pain level and everything. Now let's look at the show, the bloody show. Okay. So here is light, it increases and very heavy. The edge to push. Here they don't have any edge to push. And it goes like that occasionally. Okay. But over here, strong. Needed. What are the risks involved? If latency phase it prolongs and does not cross. So let's say at 1 o'clock a.m. it was 3 centimeters. Okay. Or it was 0 centimeters. At 7 o'clock a.m. it is now 1 centimeter. This stage is what? Progressing. It is delaying. So what will now happen? What is the risks involved with delayance? The mother will become tired. Okay, exhaustion if prolonged. Mother will become tired. They need this one should go fast, and this should go fast so that they will preserve the energy for the last phase. But they are wasting all the energy here. By the time they get here, they don't have energy to push. Okay. What are the risks involved with this? The active phase. There is hyperventilation. Okay. When you hyperventilate, what happens? You blow out your CO2. We need this CO2 to go to what? The brain. To activate the respiratory center For you to be able to breathe, it is not oxygen. Your body does not need oxygen for the lungs to be able to breathe. It's like buying a car. It's like buying a car. Okay. When you buy a car, you buy fuel into the car. The fuel is the oxygen. Now you filled your tank. How can this car move? You need a driver. Okay. And the driver is what we call the CO2. It goes to the brain. But if you breathe fast, you blow out, you breathe out the CO2. So there will be less CO2 in you. Okay. If there is less CO2, the brain will be like, if I'm not receiving more CO2, then it means that the body is okay. I don't have to breathe. So the body will tell the brain will tell the lungs that, hey, relax, don't breathe. Okay, don't breathe. And if you don't breathe, you will not get what oxygen into you. So that is the issue. Okay. So these people hyperventilate, and by the time they get here, they are almost passing out. Okay. The risks for the transition phase, pushing too early. When you get here, you should listen to the midwife. Don't listen to anybody. Listen to the midwife or whoever is planning you before. The person has been trained. So they will tell you push. Pushing. And you know how you should push. Okay. And all the tricks that comes with it. Okay. That's the issue. If you push too early and you tear, you cause damages and trauma and all these issues, trouble, wahala for you. Okay. Yeah. Okay. The key nursing priorities by phase. So these are the things you should be teaching your patients. So in the latency phase, the change this one to teach breathing and relaxation exercising. They need to what? Keep their energy. Encourage ambulation. Yes, it helps the muscles to be active so that it will contract so that you leave this phase early. Encourage fluid intake and provide reassurances. This is the teaching phase. In the active phase, what do you tell your patient? This is the working phase. So pain management, epidurals, assist with positioning. You monitor your fetal heart rate because we mostly detect what fetal distress in this phase. Then you limit distraction. Over here, the mothers are always focused. They are serious and focused. So you, the midwife, should help them to be more focused so that they don't hurt. So many distractions. The family is now coming to see them. This one is coming. No. They are all distractions. Okay. Then the transition phase, what goes on between you and the patient? You stay with the client always, never leave them. Provide calm reassurances. Coach them. Coach them, panting and blowing. Then do not encourage pushing. Okay, they shouldn't push fast, too early. Prepare for delivery. Because delivery is what? So here's support and safety. Support and safety. So these are the tricks that comes with it. Those who like the takeaway too. That is it. Yeah, emotional loss of control. The nurses stay close with the transition and labor phase. Now let's go to stage 2. In stage 2 is the pushing. What are they pushing? They are pushing the baby out. Okay. So if baby should come out, I should start from the service. The service should be 100% effaced. 1. effacement. So if this is the cell, this is the mouth, but it grows like this. The thickness is like this. Okay. And this is the mouth. Can we get a service that this thickness will all vanish and it will be like this? That is effacement. So the muzzle, the thickness from the top to down should compress like this. Then the width, this side, it should open, full dilatation. So for the top to down to compress and become so light and thin, we call it what? Effacement. And for the lumen to open, we call it dilatation. So note the difference. Okay. You should watch out for baby coming to lock. Some children will come with big old shoulders. Okay. That it can pass through the pelvis bones. The bones have opened up wide, but still the shoulders of the baby. So over here, you watch out for shoulder dystocia. It means the shoulder is locked. It's not coming out. Okay. So over here, what do? You do your Mark Roberts. You elevate the leg. Okay. Then you put pressure on the pubic symphysis, called the macro. Okay. So suprapubic pressure, then you elevate the legs. Okay. Now, third stage, baby is out. If baby is out, baby was connected to the mother with what? Placenta and umbilical cord. Okay. So we need to deliver the placenta. So what are the signs we are looking at? Gushing of blood. We get that. I have taken the placenta out. Why am I seeing plenty blood gushing? Okay. I have torn the placenta and torn the tissues of the uterus. 20% of cardiac output goes to the gravid uterus. So that is what you should know. Okay. So, and cord lengthening is very important. The length of the cord, you assess your placenta. Then also, you sometimes when they are tearing, because the muscles of the uterus are weak, it invaginates or it inverts. So we call it uterine inversion. Okay. Now let's look at stage 4. And gradually we are finishing today's course. So stage 4 is the immediate recovery. The first 15 minutes, 30 minutes, 45 minutes, 1 hour. Sharp. Monitoring of the mother and the baby. Okay. You monitor them, the hemodynamics. Who is losing blood? Who is losing oxygen? Who is bleeding? Who cannot breathe? Who cannot cry? So all these things you should. So that is the 4th stage. Okay. Right. So let's look at some of the things. So now that we are done with the phases and baby is out, placenta is out, mother is free, child is free. Let's do a recap of everything we've done. During the contraction, there was a relationship between the mother's contraction and what? The fetal heart rate. Okay, so a normal fetal heart rate is 110 to 160. It should not go below. If it goes below, we are looking at cardiac arrest. Okay, so it can put the baby into distress or fetal bradycardia. If it goes high, proper distress, about 170, 180, and all this one. Okay, so we have acceleration, variabilities, decelerations, and all those stuffs. Okay. So let's look at the mother's uterus contracted. This is the big uterus. This is my child. This is the placenta. Umbilical cord. But remember, this placenta is receiving blood from the mother. Like this. So it's like blood is coming here. And this is the junction. And another blood is continuing from here to the baby. So this is the heart of the mother. Okay. When the muscle of the uterus contracts, they cut off blood supply. Cut off blood supply. Oxygen, blood is a connective tissue, carries oxygen and nutrient and everything. So they cut off. So what if these muscles contract for 3 minutes? Can this baby survive oxygen cutoff or blood supply and venous return for the next 3 minutes? Mother will survive, but this child cannot survive. Okay. Because this baby cannot talk when they are in the uterus, how do they communicate with the outside world? They communicate with their heart rates. When they come out of the uterus, they communicate with crying, cry. Then the language will change, develop, and it becomes normal language like you and I, we can speak. But once they are inside the uterus, they communicate with their heart rates. So mother is healthy, child is healthy, but physiology is taking place here. The walls of the uterus, the muscles of the uterus is contracting, and it is cutting off. Okay, so do I have to study the heart rate of the mother? No. I have to study the contraction of the mother and study the heart rate of this child. Okay, so ideally, when the heart rate, okay, when the contraction is ongoing, if there is contraction ongoing, as you see a reaction, the word is what? A reaction. Joanna, do you understand?
Yes, please.
If I hold your nose, close your mouth, put your head underwater, won't you react?
I will react.
The same thing is happening here. So if the uterus is contracting, the heart rate of the baby should react and tell us that no, I'm suffocating, you are killing me. Okay. Okay. So we arrange them. There was a contraction. At the time the contraction was ongoing, from the beginning to the end, what happened to the heart rate in this phase, this small phase? So that is where I am more concerned. Did the heart rate reacted to it? Okay. If it reacted to it, then we call it that, oh, this one is okay. There are some people, they will come to the hospital in the face of contraction like this, that we expect the heart rate to react. when this one is contracting, this one will not react. It will wait. After the contraction that you see the heart rate also what? Decelerating. You see the heart rate coming down, dropping. Okay. You see the heart rate dropping. What is happening? That when the muscles were contracting, the heart rate didn't do anything. After the muscles have finished contracting, that is where the heart rate is coming to react. Okay. There are some people too, when this is the contraction phase. Okay. During the contraction phase, heart rate didn't do anything. But you know what happened? Before the contraction started, then the heart rate started dropping. Why is it that the heart rate of the baby is dropping before contraction? Because I have done all these pathographs. The muscles of the uterus are not contracting. So what is causing my heart rate to drop, even in the absence of what, or before the occurrence of contraction? These are the things the midwife will take and do the analysis and tell you that, okay, now let's go down and see what happened. The heart rate contracting early, okay, or the heart rate dropping before the contraction of this. They look at so many factors and they say that, oh, okay, this one might be head is compressing. Head compression. So this umbilical cord, it can be that the head of the umbilical cord is too long, that it is sitting on one pelvic bone here. The bone is here, this is the uterus. And the head is pressing on the umbilical cord. So that communication that was supposed to break here, when this one is contracting. Now there is no contraction. Blood is flowing, oxygen is flowing, but when it gets here, the head of the baby will be pressing on this. So there is a break. Instead of the break should happen here, the break is happening here. That is why contraction has not happened, has not occurred yet, but I am seeing what? Heart rate dropping. So what? We look at some of the causes at head compression. Okay. Anchors to say is normal. Early decelerations are normal. Okay. What do I do? I'll just reposition the mother. The head will be relieved and blood will flow. Do I have to give the mother medication? No. Do I have to put oxygen on the mother? No. I just need to reposition. Okay. That's it. Or sometimes I don't even do anything. Okay. Now, let's look at what the variable. Sometimes it varies. At this point, when contraction was ongoing, the heart rate decelerated. The next cycle, when contraction happened, the heart rate, yes, it decelerated, but not that much. This is a variability. The next cycle, when contraction was happening, I rather saw the heart rate accelerating. So in these three phases of contraction, I have seen variable reactions. So this one too, English will say that sometimes you are looking at the cord, sometimes yes. So some people can give oxytocin or sorry, they will stop oxytocin, or they will do the normal repositioning. Okay. Let's go and look at the late one. Contraction has occurred. In this same phase, heart rate is normal. But after the contraction, then I am seeing heart rate dropping. We call it what? Late deceleration. The heart rate went down, decelerated. So what is happening? This is the uterus. The baby is here. The cord is connecting. The placenta is here. And this is the heart. So the blood is coming from the mother to the child. When it got here, we have something we call uteroplacental insufficiency. I am not getting enough blood. So there is a break in communication here. What is the intensity of this contraction? Are we giving the mother any uterotonics that is causing the uterus to contract? Are we giving any oxytocin? Are we giving any cytotech? All these uterotonics, okay? So the blood from the mother to the child, what is the blood volume? What is the cardiac output of this mother? That the amount of blood, if the mother sends 1,000 mils of blood to the child, how much is getting to the child? We are getting only 400 mils. So there is something going on. Is it about this junction? Is it about inside this? So yes. So what do we do? Okay, let's turn the mother to what? The left. The umbilical veins that are taking blood and all these ones. We have something we call the aorta cava, the aorta and the inferior vena cava. They meet. Okay. So aorta cava compression. This is always at the left side of every human being, especially mothers. No, on the right side. So if this is the human being, the heart pump blood is coming. It will distribute to everywhere. When it is about to go back, venous return, there is a junction here. It will pick the venous return and send it to the heart. It is on the right side of the mother. So if a woman is pregnant with all this big belly, sleeping on the right and compression, this blood supply will cut. So let's turn the woman and put the woman on the left so that this one will be relieved. So that's what we do. We give oxygen. Okay, the blood that is carrying the hemoglobin, is the hemoglobin having enough iron? Is the hemoglobin good enough to carry oxygen? So let's give oxygen. So these are all treatment modalities we do. The IV fluid to increase blood volume. The oxytocin and pitocins, we stop them to reduce contraction. Then you notify your healthcare provider. Okay, these are the things you do. So people have sat down and they brought all these acronyms. But I don't have to learn it. They call it veal chop. The veal. Okay. So, and these are the treatment or the courses. Okay. HP. Okay. So when I have a variable deceleration, what should I do? I'm suspecting what? Cord compression. Okay. So if I reposition the mother, I'm okay. I don't have to give any medication. So it's accepted. Early deceleration, the head is pressing. Okay. So yes, I can sometimes I don't do anything, I can reposition, life goes on. So that one to jet accelerations. Every mother wants the baby's heart rate to go up instead of drop. So even when there is contraction and the heart rate is going up, it's good news. So always acceleration is okay. Who will carry baby for 9 months and they will come to the maternity room and the midwives will tell them that your baby's heart rate is dropping? Will be happy. Okay, everybody wants the heart rate to go high. So acceleration is always okay. Whether blood has stopped on the way, whether oxygen, whether fluid, whether whatever compressions, I want what my heart rate to go as accelerations are always okay. The bad side of this or this grammar we are saying is the late deceleration. Contraction has happened. In the same phase, I am expecting the heart rate to react. It didn't. It is after I am seeing it. So what is happening? Placenta insufficiencies. Placenta insufficiencies. It can kill your baby. It kills a lot of people's babies. There is all these pregnancy-induced hypertensions, preeclampsia and eclampsia. It causes this guy. It will damage you. Okay. Okay. So on the last note, epidural safety. Anytime you give epidural is very silent. You will not feel contraction. The mother will be having peace. At the active phase, that the pain should go high, pressure should go high, mother's mood should change. You have given epidural to block the pain nerves. So all this drama, the patient is not experiencing. If you are not careful, they will cause what? Maternal hypotension or fetal bradycardia. So you give a lot of fluid to the woman to increase preload. Mother should be on the life side, and you check your blood pressure every 5 minutes for the next 15 to 20 minutes, or just keep eyes on the blood pressure. Okay. Yeah. So this is epidural. Guys, we come to the end. We come to the end of everything we've done today. Any questions so far?
Yes,
Yes.
sir. But when are we supposed to give the epidural?
Come again.
When are we supposed to give it, the epidural?
Epidural is supposed to be in the active phase. So you'll be monitoring the cervical dilatations when it is between 4 to 7. Okay. So always when it enters 4 cm, or if you want to be sure, 5 cm. That one, you know you are in between, you are above 4. Okay. So 5, 6 cm, give you epidural. So 4, 5, 7 cm, you are almost leaving the active phase to latency. That is not the time to give, because if you give epidural, you should be managing this. The time, and remember, when we leave active phase, we are going to transition. This is the phase that you won't allow the mother to be walking around. You will take the mother to the delivery bed. So on the delivery bed, will you be happy as a health worker to be managing hypotension for the mother, bradycardia for the when would the mother be able to push? Baby will die. So if you want to do epidural, start early, 4 cm. So 4 cm, even if 4 cm, 5 cm, 6 cm, 7 cm. Yes, so give it early. Do you understand?
Yes, sir. Thank you.
You don't need machine to monitor cervical dilatation. Any question? If no question, can we call it a day? Can we call it a day?
Hello, sir.
Yes.
I don't really have a question, but then I want to commend you for the way you teach. This is my first time of joining, and you calmed down and you've really understood. I just want to thank you for your time spent with us. We are grateful to you, sir. Thank you.
Blessing. Thank you too. Okay. Right. So guys, we meet another day. Okay. We meet on this note, we've come to the end of what? Maternity 1. So tomorrow we are going to maternity 2. Shine your eyes. Okay. Meet us online. Okay. Any question? Somebody's hand was up.
Yes, sir. Have you already put the slides on the page?
Everything, I've told you that nowadays, everything is on. I'll put everything online. So go and learn. Go and learn. Go and learn. If you are not part of the page too, you can see Eric. I got to put you on the page. Okay. Invite your friends. Where are the nursing training students? Bring them on board. Let them learn. They are going to write their exams. Okay. Yes. Bring everybody on board. Okay. If you send me a message and I'm not able to reply, don't be angry. Okay. Don't be angry. I will surely talk to everyone one by one. Okay. So please. Yes, Obapa.
Good afternoon. Good afternoon to everybody.
Afternoon.
Please, I couldn't join earlier, but I heard you saying something. I mentioned the word acceleration, decelerations. I'm not. Can you explain what it means?
Okay. So acceleration is, in short, when the mother's heart muscles, the uterus contracts. At the same time it is contracting, I'm expecting the heart rate to react. Okay. So some heart rates, even though the muscles are contracting, the uterus is contracting, but the heart rate will be going up. When heart rate goes up, we call it acceleration. When it goes down, we call it deceleration. It's just English. Don't let anybody confuse it. It's just English. Ideally, this is the mother's heart. The mother is supposed to send blood to the baby. Yeah. Okay. In between the mother and the baby, there is a uterus. And there is also a placenta. But this uterus has what? Muscles. So mother sent blood. The blood was coming. And the blood is coming with nutrient and oxygen. Okay. So when the blood was coming, it got here, the uterus was contracting, and this blood flow, it is continue, it doesn't break. From the day the child implanting the uterus and the placenta and everything forms, this blood flow will be going on till the child is born. Okay, it will be going every second. Okay, every second. But at the latter part of pregnancy, in labor, when contraction starts, the blood was sent. When it got here, the muscles were contracting, so it should not go. It couldn't go to. So that brief period of break, you will see a reaction in the heart rate. Because I've told you that the heart rate is the way the child inside the uterus communicates. They talk to the outside world. So then the heart rate is between 110 to 160. Okay. So when the mother is contracting and the heart rate at the same time, heart rate is accelerating, we say that this is a good sign. Okay. Now, at a point, the mother, or we have some pregnant women, the uterus is contracting, but the heart rate, you will not see it reacting. It's normal here. The heart rate is normal. But after the contraction, then you see the heart rate dropping. There are some too, there before the uterus will contract, the heart rate will even drop down before the uterus will contract. This is what we call the head compressions. Early, the head. Okay. Late is the placenta insufficiencies. And we have the accelerations. Okay. Then talk of the variable decelerations. Okay. Let me clear the board. So I have given you 5 different or 3 different contraction phases. Okay. 3 different contraction phases. I want to study all of them. I realized that in this contraction phase, the heart rate was normal. In this same in the next contraction phase, I saw what early accelerations or early decelerations here. So the heart rate was outside here. It occurred fast. Then on this third one, it came back to normal, or it was inside here, but it decelerated. Then maybe over here, the contraction and this one, what? It occurred here. So when I compare all these 4 guys, I'll tell you that what? I don't have a consistent reaction between the contractions and the heart rates. So this is called variable, okay, reactions. Variable reactions, okay, or decelerations. About Papa, you understand? Let me leave you guys. Okay.
Thank you very
so
much.
much. We meet another day. Go
God
online.
bless
Sir,
you.
thank you very much. God bless you.
God bless you too.
He said, God bless.
Okay.